Well, good evening, everyone, and welcome to MacTalks, a series of conversations with McMaster researchers who are leading the way in finding solutions to some of the world's most pressing challenges. My name is Karen Mossman, and I'm Vice President for Research at McMaster. Tonight, I'm absolutely delighted to welcome André Picard, award-winning health columnist at the Globe and Mail. André is the best-selling author of Neglected No More, a piercing look at the state of elder care in Canada. He's an 8-time nominee for National Newspaper Awards and has received the prestigious Missioner Award for Meritorious Public Service Journalism. André is joined tonight by McMaster's own doctors Don Bowdish and Andrew Costa. Dawn is a professor of pathology and molecular medicine at McMaster and Canada Research Chair in Aging and Immunity. Her research focuses on understanding how the immune system fights infection in older adults. Andrew is the Schlegel Research Chair in Clinical and Aging and is an assistant professor in McMaster's Departments of Medicine and Health Research Methods, Evidence, and Impact. Andrew studies evidence-based care and health policy affecting older adults. Together, Dawn and Andrew are leading one of the largest studies on long-term care homes in Canada to find out how well vaccination works in residents and which features of these homes could be linked with outbreaks. Now, let's join André, Dawn, and Andrew to look inside Canada's long-term care homes.
Great. Thank you very much, Dr. Mossman, for that kind introduction, and welcome to everyone to our panel, Outbreaks, Vaccines and Immunity Inside Canada's Long-Term Care Homes. And we're going to explore a bunch of issues. We've already received some questions in advance. We urge you to submit some more questions, and I'll work them into our conversation. But I have a few of my own. As you heard, I've spent some time last year, writing a book on this topic, so I have a few questions of my own, and we'll delve into a whole bunch of these issues. So Dawn, I know you're an immunologist, you're a fancy scientist, but I want to start with some really basic stuff with you. I want you to, COVID-19, we know really ravaged long-term care homes in Canada. We've had about 23,500 pandemic deaths in Canada. Last count that I did, about 16,750 of those deaths were in these congregate settings, so a really enormous number. So can you help us understand how did we get to this happening? What went wrong?
Well, a number of things went wrong. I mean, some of the features of the way we run long-term care have always been problematic. When it comes to infectious disease, it's so important to have people who are devoted to working in one home and not carrying infections back and forth. There's been so much public discussion about things like paid sick days, but this is also really important because the long-term care residents are not leaving the homes. The infections are being brought to them, and they're being brought through their staff and through the people who visit them. And so many of the features that we've been talking about, HVAC and staffing issues and things like that, have been in existence for a long time. And in fact, we've known that Canada has had a problem with infections in long-term care for decades. So influenza deaths are higher than they need to be. Some respiratory seasons, we have an excessive number of deaths just due to these colds and flus. So there's all those sort of structural features, but of course, there's also the features of the aging immune system. The people who live in long-term care are older. They tend to have lots of complicated medical conditions, which affects immunity. And many of the drugs that they're on can have suppressive effects. So when you add this to the idea we're putting lots of these vulnerable people in a place together where the infection doesn't have the barriers of a healthy immune system, you can see how spread is something that really is going to be really problematic in this particular group of people.
That sets the stage well, and you enumerated a few of the really important issues. Andrew, I want to ask you a similar question. Was all this avoidable? We've heard that historically all these problems have existed. Was it all avoidable or partially avoidable?
Some of it was certainly avoidable. What's less avoidable is the fact that, as Don mentioned, older adults living in long-term care, they get frailer by the year, and so they are at higher risk just naturally for infections and severe infections. What's been avoidable is really how we've been sleepwalking for a long time, and to take from your book, forgotten long-term care, in particular nursing homes, but really seniors and how seniors age more generally. But specifically for nursing homes and long-term care, for a long time, we've had the problem of crowded facilities, old facilities. We've known about it for a long time. There's just been extraordinary inaction. And really, it's sort of been said, when the tide goes out, you see who's been swimming naked all along. And the tide went out when COVID came in. And it's pretty clear now what all the longstanding issues are. They've really been made bare. And so poor funding, lack of training, lack of appreciation for the skills and the roles that exist in long-term care in our society, in our health system, crowded facilities, not updated facilities, lack of innovation, the list goes on.
Yeah, it's a long list. You've both listed a lot of things, so we have a lot to talk about. I guess if I come back on to your specialty, let's talk a little bit about the aging immune system. Is it inevitable that people are going to get one of these infectious diseases and die? We know they're at higher risk, but is all this inevitable? And what can we do to avoid this, not only in congregate settings, but in general? How can older people protect themselves and keep their immune system healthy?
This is a great question. So the immune system is sort of an integral part of your entire physiology. And unfortunately, the things you need to do to have a healthy immune system are the things you don't want to do, with their exercise and to eat a healthy diet. That's nature's anti-inflammatory and immune booster is exercising and eating well. And this is particularly important in the context of older adults in long-term care. So we know that in some homes, there might be issues with nutrition, really good quality, top quality food. Older adults might also have issues with dentition or things like that might be eating the high fiber diet that's so good for you is important. And then there's a huge range in the quality of homes. And unfortunately, good food is costly and that can be really problematic. Exercise is absolutely integral as we get older to keeping our immune system. And that is any sort of exercise that you can do, if it's the context, walking, any sort of mobility. So whenever we don't have facilities or homes that are really conducive to letting residents move, there's a precipitous decline in immune function and health. And, the important parts that I always tell people is infectious disease is bad for two reasons. Of course, we don't want anyone to get acutely ill. But sometimes when you're older, the thing that's more worrisome is not so much the acute infection, it's the long-term health effects. So we've known for decades that having pneumonia or influenza or mid to late life, and certainly we're seeing evidence that this is going to be exacerbated in COVID, has long-term health issues. It can really be a precipitating event that ends up in a loss of mobility, increased cardiovascular events, more issues with respiratory health, muscle wasting that leads to a lack of mobility. So the reason we need to fight infections so strongly is not just to keep people from getting sick now, but to maintain that healthy, independent living, which is so important to all of us. And so vaccination is one of our key strategies. But again, that sort of holistic effort of keeping people mobile, active, social, believe it or not, social contact's good for your immune system. Humans aren't meant to be lonely. And so in the context of this current outbreak, I worry about two things. Obviously, the acute loss of life has been horrendous, but I also worry about all those lost social contacts, the exercise, the mobility, all of these things that we know keep older adults healthier and stop future infections from happening.
And we'll come back to this. We have a lot of vaccine questions, so I'm going to come back to those. But Andrew, I want you to build on that. So we heard Dawn say to have a healthy immune system, to be healthy generally, you need good food, you need exercise, you need social interaction. That to me seems all those seem the antithesis of what life is like in these institutions. We have no staffing, so people don't really do activities. The food, you get a budget of $9 a day in Ontario for food. They don't eat like kings and queens, that's for sure. A lot of people are just chronically lonely. We locked out their families for a year during the pandemic. Have we built institutions that make people unhealthy?
We have, for a long time we have, and we inherited some and really didn't get our act together on many. And so for a long time, long-term care has been thought of as an institutional setting. And so we haven't thought a lot about what happens around a long-term care facility, but rather kind of all the conveniences that can be had for healthcare providers to provide efficiency within the facility. And so all things being equal, whatever works best for providing care was what we prioritized. The challenge is that it's not a place to receive care. It's also a place to live. And you can't live a healthy, effective life to the extent that all the advantages and all the benefits go to the healthcare providers that are providing care in those settings. So for a long time, I think the evidence is there for many of our long-term care homes. First of all, where do we put them? We put them sometimes in inopportune places. Some are joined next to parks or public facilities, or in places where you would want to walk, or places where people would want to visit and congregate around a home. But typically they're silos onto themselves. I see many on sides of highways, et cetera. We don't think about it in terms of our city planning in general, places for older adults to live in mixed living. We think about it in a much more crude way. Oftentimes, for people that want to build long-term care homes, build infrastructure, the cost of land is important. There aren't oftentimes enough subsidies for cost of land until they go to where the land is cheap, not where people want to live. It's one example of being isolated as a building. Then within the home, it's almost, in some cases, it's the worst of both worlds. Not only do we have sometimes poor facilities, but we don't have good spaces for people to congregate or technology for people to access to meet with family, meet with friends. We don't have enough rec programs. We don't encourage them, older adults in long-term care homes, to move a lot. But we also have lack of privacy within homes, where you have a lot of individuals who are living in 3 or 4 bedrooms or double rooms. That's more the standard than it is to have a single room. That's bad for privacy. It's bad for autonomy, all things we value. Bad for infection control, where you need to isolate individuals, certainly. And then when we think about the public spaces, oftentimes they're crowded. And so we don't have large enough corridors for people to move through sort of safely. We have everyone eating in the same sort of lunch hall, the same congregate rooms. That's bad for infection control. It's bad for quality of life. You don't know your neighbors and so forth. The newer designs now have smaller resident home units. So residents that are 30 or 40 residents per unit, they can live in a home-like environment, but we don't have enough of that.
Yeah, you've sort of given us a long list of why people don't want to live there, and the polls reflect that, right? People used to not want to live in long-term care. After post-COVID, they dread living there. So it's changed. It's gotten even worse. In my book, I call it our practice is elder apartheid. We kind of take people out of society and we stick them in these buildings. You're right, by the 401 or the 427, whatever, and they're forgotten out of society. They kind of lose their citizenship. So Dawn, what's the answer to this? I want to spend a lot of our time talking about solutions, but is it to knock them down and start over? Is it to change gradually? Is there an easy solution to this long list of problems that Andrew gave us?
There's no easy solution. And I think to a certain degree, it might be a little bit of a clean sweep. Of course, there are examples of really well-run homes, but I think we've talked about so many of the issues with regard to infectious disease control and mobility and all these challenges, but those of us on this panel today, we're all sort of middle-aged people who are thinking about our parents and thinking about the future and where we want to live and how we want to live. And we need more options for people at various levels of care. We need people who, can't afford to have, temporary stays when they need a little tiny bit of care in maybe one of the chain homes that are much more expensive. And we need to make sure it's equitable. I do a lot of work with older adults, and sometimes to get research participants, I visit a library program for older adults that's free. And it's run in sort of one of Hamilton's sort of code red areas. So one of our areas that's not so economically advantaged. And then I also go to a number of retirement communities to recruit participants there. And I'm always taken aback by the disparities in health in these two sides of town. It's not, as an immunologist, I look at blood and I can see how old you are. I can see how good your immune system is when you give me your blood. And I'm always troubled by the fact that I go to some of the retirement communities and I find it hard to find anyone under about 88. They're all coming to give blood for me on their way to go eat and exercise. And they have this really wonderful experience that I would love for my parents or my grandparents or anyone I love to have. In fact, I used to bring my daughter with me sometimes, and she would always kick back at the movie room and be jealous of the swimming pool. That's idealistic, and it's totally out of most of our economic ability. And so we need to start thinking about looking at countries that do long-term care well. And in the ones that do it well, they tend to have it more as a continuum of care where there are more options. It tends to be, like Andrew mentioned, people are trained to deal with the complexities of living longer. As we live longer, we tend to have more complicated health conditions, all of which are manageable, but need more skilled workers. And we need to make this equitable. I worry so much about equity in healthy and unhealthy aging. And I know this is an issue that's dear to your heart as well. And so I think this is why we have to have standards nationally and maybe provincially and locally to make sure that we're not perpetuating the inequality of who gets to age well and who doesn't.
And a couple of really important points you've raised. One about the choice. We don't have a lot of choice in Canada. Everybody's kind of funneled towards institutional care. We don't have great home care, for example. We don't have much intermediate care between the home and the long-term care facility. So some issues. And then the money. As you mentioned, there are great homes, but a lot of them are costly. You could pay $2,000 up to $15,000 a month in Canada for a decent home. So it's the equity piece of the puzzle is a difficult one. So Andrew, what we've mentioned a couple of times, and I think it's important to underline that there are good homes. So what is a good home? You know, we don't want to totally frighten people. I think your last answer may have frightened us all half to death, but or at least frightened us about aging. What is a good home?
Yeah, I don't mean to think that people shouldn't be under the impression that individuals living in long-term care homes are miserable. Some certainly are, and we need to pay attention to that. And we don't want that, but many are quite happy. I meet many that are quite happy. Many live in homes that are communities, and there are communities within communities. As we get older and we grow to a certain level of dependence, this is to some extent an example of our success, that we are growing older. But towards the end of life, when we try to shrink it, we do develop certain dependencies, things we can't do for ourselves. In those cases, to live in a congregate environment is very attractive. It's kind of a microcosm, the same reason why some people choose to live in cities, because there's good access to resources closer to you. And a microcosm of that is living in congregate care for older adults. So it's sort of a necessity. You're close to services, you're close to things you need, and that's really important. Good homes are good communities. And so there's friendships, there's social opportunities, there's spaces that allow for it. That's a really important thing. They don't just happen on their own. There are people that allow for it. There are opportunities for permeable space between what happens inside the home and outside of the home. Obviously, that has to change when there are infectious disease issues, but in good times, that's certainly the case. And there are places where you can access the things you need and where people want to come in. I've had beers with residents in long-term care homes because Friday at 3:00 is happy hour, and that's fantastic. And there are social opportunities, there are social events, and that's really what we want, is social opportunities. You know, I think it would surprise a lot of people. You can never judge, I guess, a book by its cover. It's a classic thing to say, but it's also true for long-term care homes. You know, you'd be surprised how happy people are in some long-term care homes that you look at from the outside and they might look a little shabby. And that's because of a couple of things. Number one, the staff working in there love the residents, and they've been there for their entire career and they know everybody like the back of their hand. They attend funerals, they are part of the family. And that's really the most important thing. So the bells and whistles that, the things that meet the eye, they're important. They certainly are, but they're not the most important thing. It's those personal relationships, the community surrounding, opportunities for recreation, for intergenerational activities like having daycares close by and so forth, parks and so forth, really important. But it's the community within it's important. Sometimes when you see facilities that have all the bells and whistles, sometimes the culture isn't great and it's not a wonderful place. And so it's about people.
And that's what healthcare is all about, people caring for people. There's a famous quote, Pat Armstrong says, the conditions of work are the conditions of care, right? So if the employees are happy, if they're well treated, so are the residents generally. And you make this important point. It's not just about infrastructure, it's about environment, it's about culture, it's about philosophy. Everything I heard you saying between the lines was it's about providing patient-centered care, right? Putting the emphasis on the patient, not on the tasks. And that's what I hear are the best facilities. So Dawn, I'll come back to you. There's a question people are asking about research. Essentially, we seem to know all the problems. So what do you need to research, and what are the particular challenges of researching in this domain?
Mm-hmm. The aging immune system is full of mysteries, and this is going to keep me employed for a long time, and it's really exciting for me because we know that a healthy immune system is associated with a long and healthy life and more active life, and we know that an unhealthy immune system is associated with premature death and an unhealthy life. So one of the things that my global research program is understanding that interplay between health and frailty, which is a lack of resilience that a lot of people living in long-term care have. And in the context of vaccination, I think it's always really surprising for people to know that, it's not a blanket, your immune system magically stops at 65. That is not what happens. And in fact, we see that there are people who have incredibly resilient immune system into very late life. And so in every study I've ever been involved with looking at frail older adults and either vaccination and infection, there is an enormous range of people who are truly almost young looking in how they respond to that vaccine and infection. And then there's people who are truly compromised. And so understanding that is absolutely important for us because it helps us design things like vaccinations. Now, in the context of the current outbreak, it's an incredibly exciting time to be a scientist. Our mRNA vaccines, which our residents have got, have overperformed past all expectations for a frail older adult. If this was an influenza pandemic, in many cases, it's far more efficacious to vaccinate the staff and the visitors because the vaccines just work so poorly in long-term care. But here what we're seeing is that these vaccines have truly made a huge difference. Although they are not perfect, and we will always expect that there will be breakthrough infections in some facilities, because of the vagaries of the aging immune system, they've helped to keep those smaller and better. But I have to say we're in a really dangerous turning point in this pandemic, where we know that these vaccines work far better than we expected against the original virus. But now as we're seeing this transition to these variants of concern, we would expect that people who make an imperfect immune response to begin with are going to be the ones that are the most valuable. So one of the things that Andrew and I are doing in the context of our study is we're trying to understand who's got a good immune response to the vaccine and who doesn't, who is going to be most vulnerable to which variants. And we're hoping to use this data to be able to inform policymakers and about what are we going to need next year. Are we going to need booster shots to this variant or that variant? What can we do to make sure that we keep this level of protection in frail older adults? And frankly, right now, we're having to make decisions based on guesses, not data. And data is always better than a guess. So this is going to be a really important turning point for us to help mitigate what could be a very difficult 2022 or 2023 as these variants become widespread in the population.
And we heard the CEO of Pfizer say this afternoon that we'll probably need a third shot a year after the being fully immunized. So this is not over. It might look more like the flu shot annually or something. Now, Andrew, you're also a researcher, but you're a health services researcher. What do you need to know that you don't know? You seem to know a lot of stuff. You gave us a long list of what's wrong. What else do we not know?
There's so much we don't know. I think we've had a breakthrough of research in long-term care with respect to COVID over the last year. We've understood a lot around the dynamics of spread, how that's affected by community transmission rates, certain aspects of ethnic concentration in certain areas, workers' movement patterns, the movement between obviously long-term care homes and the design of long-term care homes. What we still need to understand a little bit is around some of the inequities of funding and staffing and how those influence outcomes. We know they influence outcomes, all other outcomes, and we can assume they influence COVID, but we really want to be able to quantify that, partly because we really want to think about what's the long-term care system for the future. And what is the relationship between these things? If it's a very strong relationship, which it's always proven to be, then it suggests not only is more staffing good for long-term care because of quality of life, quality of care, but it's also extremely important when we have incredible infectious diseases like COVID. But every wave has been just an incredibly different scientific challenge. And so when we first started the project that Don and I mentioned, we were really looking at spread and infection and really trying to narrow down some of the indicators. And we understood the surface level indicators, things that we can understand from a home level, but we didn't understand the individual data for residents. So we could say which homes were at greater risk across the province. We could prioritize, and we did prioritize around those, but we couldn't understand which individual residents were most at risk. That was our original goal. But the vaccine came, and really thankfully it did. And now the questions have shifted because they've been so effective around what is the effectiveness of the vaccine? What can we predict going forward? To the extent that we have vaccine escape, meaning the variants, new variants, emerging variants, challenge us in long-term care, then we're back to the old conversation around trying to predict that risk, trying to understand where it's going to pop up so we can address it. So it's basically scientific whack-a-mole. And for me, what's a health service researcher? It's someone who knows a little bit around the dynamic of healthcare and is trying to think forward on that, but also in my case is an epidemiologist, so I go where the numbers go.
And Don, your previous answer generated some questions. We have a lot of students, researchers in the audience, and some people want to know, can you talk more about the study? What's the scope? What are you trying to find out in your study?
I'm so flattered. Thank you. It's, this is a weird time in history where all of a sudden everyone wants to hear what scientists are really into, and people are interested in immunology in a way that they haven't been historically. So effectively, our study has engaged, we've got 23 nurse home across the province of Ontario, from the north to central western areas. And what we're doing is looking at immune system of the residents. What we're doing is we're taking, our participants are donating blood for us so we can look to see if they've ever had an infection, because one of the strange things about this infection is even in frail adults, we have a lot of people who don't have any symptoms. And so we'll be able to say how many people were actually infected in the course of this. And then we'll also be looking and saying, how well do they respond to the vaccine? And from an immunology perspective, that will be two major types of immune responses. We'll look for antibody levels. How long do they last? How well do they bind? Older adults tend to have not very sticky antibodies, so we're really worried that that's a way in which the virus, especially these new variants, can escape if those antibodies don't stick very strongly to it. And then we'll be looking at their white blood cells and seeing how much memory it can have. So will these be long-lasting immune responses? We're also doing saliva surveillance. So we have a way where you basically drool into a tube, and that allows us to track any hidden infections, including those of new variants in both the residents. But what's also been really wonderful for us is we've had lots of participation with the staff and the visitors themselves. So effectively, a visitor comes to the home, they drool in a tube, and then we check that to see if there's any virus. And in this way, we'll get a sense of virus that might be coming in, especially in people who are only partially vaccinated. So you can imagine that most of us right now, most of the staff are vaccinated, but they may not have had both doses. And many of the visitors, especially the older ones, will have had at least one dose. But we're not sure if that means they'll still be carrying the virus. So we'll be tracking this really, really carefully in the homes. We'll be looking at all these different immune factors, but we also have great participation from our partners who are helping us also understand, what medications are people on? What health conditions do they have? How frail are they? And in that way, we're going to learn a lot about the aging and frail immune system in the context of this infection. So that's sort of my side of the story. And as Andrew said, he's also looking at many of these facility-wide patterns so we can really understand which are the features that are associated with these entry of these infections into the homes and keeping them safe. So it's a large study. We're hoping to recruit by the end of it 2,000 residents and probably slightly more than that, staff and visitors. And we couldn't do it without wonderful partnerships, and we're incredibly grateful for those.
Well, I'm going to retain one important thing from that. The next time my kids complain that I'm drooling, I'm going to say, I'm not a messy eater, I'm doing science. So I'll give myself an out on that one. Now, Andrew, I want to take you to the other end of the spectrum, far away from the blood and the science, but maybe this is a bloody topic as well. Quite a few questions. It comes up every event. For-profit care, is that the big problem? Is it these greedy profiteers, or is it more complicated than that?
It's always more complicated, always more complicated. And so, I mean, in this case, the complication is that the evidence suggests pretty clearly that across the most studies, there's a small but consistent sort of factor that suggests that for-profit care, where it's looked at, is a little bit less in terms of quality or outcomes compared to not-for-profit care, or in our setting, homes that are municipal. And it's small, it's a little bit inconsistent, it is there. And the challenge is that I think most readers of it would get the sense then that some of these small differences then are consistent across these categories of for-profit, not-for-profit. But when we look at it, and as soon as you eliminate the bad apples, you see a lot of equivalence. And that's because in healthcare, we always find this: you get what you pay for. And some of the underlying funding dynamics, I think, are poorly understood in long-term care. And so oftentimes what the difference we see across the for-profit, not-for-profit, and municipal is actually matches pretty closely with some of the overall sort of funding differences between them. And if we are to think very pragmatically in terms of what can we do now, what levers do we have to increase the quality of care, decrease the impact of this pandemic, basically for $1 invested, you will get almost all that dollar back if you invest it in frontline care in terms of outcomes and quality of care. To the extent that we would substantially change the system and its structure, whether that's good or bad, it wouldn't be the immediate thing because it would probably be detrimental in the short term, that shakeup. And for the evidence suggests pretty clearly, for every dollar we would invest in doing that, there would be pennies coming back to us in terms of quality of care, because the difference really is in the absolute amount of care we provide. There's other things. It gets a little bit boring, I suppose, around for-profit, not-for-profit. And what people should understand, I think, is that because for-profits, as Canadians, we don't want for-profit care. That's an absolute in our country. I think we can all agree on that. The difference and some of the cloudiness here is that long-term care is provided by substantially for public funds, and that's true across the board, but it's delivered by, in some cases, for-profit companies. And there's a distinction there, and we have it across our system. But it is something that we should be thinking about and addressing. We don't want to change the balance of long-term care. For me personally, I think I like choice. So I like it when we have different models of delivery because we can compare them as we are comparing them. And we can keep all the groups honest and really maximize the benefit of each model.
And it's further complicated by the fact we're not just paying for care, we're paying for housing, and profit in housing is kind of normal in this country and elsewhere. So it is hard to tease that out sometimes.
Absolutely is, and the capital constraints are huge. It's a big money issue in our system. If you total up the physician services, the per day cost, although it seems paltry at the individual, like I said, $9 raw food budget per person in long-term care. How can that possibly be enough? Huge complaints there, obviously. If you total all the dollars we spend publicly in long-term care, it ends up being something like 25% of that entire health budget. So it's a huge amount. So what people have to realize that practically at the end of the day, when we think about increases there, it's a big problem for government to find those dollars. And so our options are not endless. And so the obvious thing in front of us, which is what people have been pushing strongly for, is more care, better care.
Yeah, getting more value for the money we do spend to start off with, and then figure out if we need to spend more. Now, Dawn, I'm going to, I guess, just keep shooting the lots of vaccine questions coming in, so I'll send them your way, even though they're not necessarily about immunology. So a couple of things. One, always questions about why aren't staff getting vaccinated. That really rankles families. So maybe start with that one.
Yeah, so I've always been really interested in why people are not confident in making a vaccine choice. And, the answers for this particular vaccine, I think, are nuanced and they deserve some thought. So as an example, I am running a small study of Hamilton residents to figure out how many people got infected. And as soon as the vaccines were available, I had all sorts of my study participants emailing me and say, Dawn, I've got this condition or I'm on this medication. Is it safe for me to get the vaccine? And when you're doing a major trial quickly, like all the major trials that we did, you don't include people who are on immunosuppressants because they're not going to have an appropriate immune response. And you exclude people in some conditions. And so the answer, truthfully, is we don't have data for people on certain kinds of medications and a certain kind of health conditions. And so when these poor people go to their doctors or their healthcare providers and say, and these are very common things, immunosuppressants for things like rheumatoid arthritis or certain Crohn's medications, things like this, very, very common conditions. Even some people who are on some treatments for asthma were excluded from these trials. And so they go to their doctor and say, is it safe for me to be vaccinated? And the doctor says, I don't know. We don't have any data. And so we're seeing a significant amount of hesitancy from people who just really are not hesitant for the conventional reasons we think that they don't want vaccines. It's just people aren't able to give them good data. Another example would be I had a number of my participants write to me and say, I'm a healthcare worker, but I'm pregnant. And my doctor can't tell me if it's safe or not. And so that is a whole class of people who are just doing a wait and see approach because they legitimately are struggling to find the answers they need. And so that's, we estimate that's a pretty significant proportion of people are refusers. Now, on the other hand, what I think your person was referring to was people who are refusing. And unfortunately, what we're seeing with this vaccine and with many other vaccines, we're seeing that there is a racial divide and a socioeconomic divide in who feels comfortable with the vaccines or not. And, I was a few months ago, one of my Indigenous colleagues had was saying, her constituency had said something along the lines to her, if these vaccines are so safe, why are they only giving them to the older people and us, the people they don't care about? And when I think about that perspective from that group, I think I can see why all of a sudden there's that concern. And so, unfortunately, there is a little bit of lack of confidence in certain groups. And unfortunately, we have a lot of people who are, may not have English as a first language who are working in the healthcare field or, don't have a really strong relationship with their healthcare provider to ask these questions, that sort of thing. And so we're seeing a lot of that as well. And I think, one of the things that we need is we need community leaders, people from temple, church, or community groups who will be ambassadors for vaccines and speak to people in a way that, they may not trust Andrew and I with all our fancy ivory tower credentials, but, sort of influencers within the community. And so we're seeing some of that too. But I would say the majority of people who have reached out to me are concerned for two reasons. Everything seems to have gone so quickly. They're just not sure it's safe and they want to wait it out. I see another class of people who are struggling to get the vaccine. If your vaccine center is 3-hour bus ride from where you live and work, that can be a huge economic barrier for some people. And then I'm seeing people who, just need to wait it out until they feel a little bit safer with that. So those are some of the problems that we're seeing in this context right now. And we're just going to have to work extra hard to build public trust.
Can I butt in, André, there for a second?
Yeah, jump in. Yeah,
I'd say, overall, I'd say we really should be cautious and we can't blame people in long-term care for not getting vaccinated. I think we're missing some of the important factors. Number one, for these individuals overall, they've been at the front lines of this pandemic doing really hard work for a very long time. And as long-term care has sort of come under public eye, or some of that has spilled on to long-term care staff. And, that's not something, it's something we really, really want to avoid. Number one, some of them are vulnerable. They're new Canadians. They don't speak English, as Dawn mentioned. And so we have to ask ourselves, have we been effective at delivering the message? And have we made it easy? I don't think we've made it as easy as we'd like. Overall, I think people should be quite confident overall as best we know, the vaccine rate for staff in long-term care is about 80%. And that's not terrible. Now, there are gaps and there are misses, and it looks a bit different depending on where you go, but that's not bad overall. For the most vulnerable, those that are working shifts, double shifts in different, well, not in different places these days, they have poor access to transportation. When are they meant to go and get the vaccine? In some public health units, we're actually not allowing, when we go into vaccinate residents, they're not allowing staff to be vaccinated on site. They have to go to vaccine centers. When do they have time to? Their access to transportation, booking, et cetera. I think there's a lot we could do to increase that number, because I think a lot of individuals that might have said no the first time or never really had the opportunity would be happy to be vaccinated now.
Yeah, and as Dawn mentioned, a lot of people from racialized communities, immigrants who have good reason to distrust health systems from where they came from. So that distrust, there's no paid sick days if you have a reaction to the vaccine,
Exactly.
A whole bunch of piling on. It would have seemed sensible to me to just have vaccinated staff at the same time as residents, but we didn't do that.
It happened in some cases, in other cases it hasn't. And now where we're going into vaccinate new residents who are being admitted to long-term care, oftentimes we're not allowing staff to be vaccinated at that time.
Mm-hmm.
And Andrew, while I have you, I'll throw another question at you. It's about, can we measure the impact of the isolation of caregivers being locked out? We know the numbers, the horrific numbers about COVID deaths, but there's all these unintended consequences of isolation, of loneliness, et cetera. Can we measure that?
It's difficult to measure. We can do it in time. Immediately, it's challenging. It's difficult to quantify the isolation. Individuals who have family members, they can quantify it very, very easily. As a statistician, it is very difficult oftentimes to measure some of the most important things. That's an important thing. We have mixed evidence, I can say. We know that because oftentimes the isolation has been tied with serious outbreaks as well. And oftentimes when staff situations and outbreaks get out of control, where you have a lot less staff, you have a lot less communication with family. And so all these things go hand in hand. There was some evidence in Atlantic Canada where they had very few outbreaks, that the impact of the isolation from family wasn't as bad. And that's because even though family couldn't enter in as often, there was good staffing levels, things were under control. The staff really picked up, as they always have, worked extra hours, made sure there was as much communication as they could possibly have with family through Zoom calls, et cetera. And we see no impact in terms of rates of mood disorders, et cetera, which we do measure in long-term care. Elsewhere, and particularly in Ontario, where we've had bad outbreaks, that and the isolation have gone hand in hand. It's difficult to tease out, although in the fullness of time, we'll be able to understand it. There's no question that there's been the pandemic has been deadly, not just because of individuals dying of COVID, but also because of mistakes, errors, oversights, and individuals essentially, to some extent, languishing slightly. Good example, nutrition. Nutrition matters, particularly when you're older. And if you're not paying as much attention to residents eating a good quality diet, which is difficult to do at the best of times, given our, the food budget we keep mentioning, that has a detrimental impact. Oftentimes we see it later and it's difficult to tease out.
And I'll just add one, if I could, about, we don't talk a lot about the trauma of this, of the mental health impacts. If there's homes where 50, 100 people have died, if your roommates are dying beside you, that's going to have an impact. It's going to really devastate you. And again, that's hard to measure. So Dawn, I'm going to come back because the vaccine questions keep coming in. This is one about the wait for the second shot. So twofold, I'll smudge a bunch of questions together. One is people are wondering, are elders in care, are they getting their 2 shots? And then they're interested in your views on, is what Canada's doing, is it dangerous? Is it right to have this long spacing between shots? Will we pay a price for that?
Yeah, so this is an excellent question. Currently, our long-term care residents have had their on-time shots, which looks like it's really important because in the very, very little evidence that's come out, it looks like they did not have enough of an immune response with that first shot, so they really did need 2. And by keeping them together, that gets them as protected as quickly as possible. Now, what about the rest of us? This is where it becomes difficult because we don't have data from the current vaccines we have. What we have is a few decades of experience. So if you cast back to any of our listeners who have kids and you think about when did your kids get vaccinated, and for all those repeat shots they have, you may remember that they were usually about 3 months apart and between 2 and 4, depending on your jurisdiction. But we know from decades of sort of vaccinology that 12 weeks, give or take a few weeks, is really a perfect time to have a second shot. And at least with the Pfizer and Moderna, when they compacted that, it was really because they were thinking, in the context of a pandemic, we want to get people as quickly as possible. So they tried a really short one. Normally, we would put it a little farther apart. We know that from countries that have gone and done a full first shot, like Israel and even the UK, we can see that it really helps bring down the levels. And I think in provinces like Ontario, where we're having just such catastrophic infection rates right now, getting people vaccinated quickly is with even one shot is probably going to help. But we also can look at countries like Chile, which did a great vaccination campaign, but allowed a lot of other measures to fall apart quickly, the mask wearing, the traveling outside the country, et cetera, et cetera. And they're seeing a lot of problems with new variants escaping from those. So in the interest of short-term reducing vaccination, I think extending that shot a little bit longer, we don't have data for these vaccines, but based on decades of knowledge, is probably not going to be problematic for healthy people, for long-term care residents, and perhaps for individuals who have are on immunosuppressive medications and things like that. They're going to need those 2 shots to be fully protected. It's probably the right decision for now. I hope not to be wrong because, like I said, we don't have specific data, but we are in a very tenuous position because those variants of concern love to squeak under an imperfect immune response. That's their way in. And I wish our vaccine campaign had started 3 months earlier because I think we would have been in a lot better place with these circulating variants. So it's the best we can do to get those rates down in high infection rate provinces like Ontario. It may have impacts in some of these variants of concern.
And just to follow up on that, a related question, they're wondering, are long-term care residents safe now? They've got their 2 shots, or are the variants still a threat?
This we don't know, and this is a major feature of our study. Some yes, some no, but which is which? And we do know from breakthrough outbreaks now that they're smaller, fewer people get ill, and partially, that there's a few things. There's a vaccine that's helping with that. There's also procedural changes that we understand a lot better, not having 4 people per room, et cetera, et cetera. But one of the major points of our study is to figure out, can we make predictions about who's safe and who's not safe? For example, are people on these medications going to have not imperfect responses, and are they going to need extra care and protection when there is an outbreak with a variant of concern? They are safer than they were pre-vaccine, but in long-term care, it's really important that we sort of calibrate our expectations. There is no vaccine on the planet that can fully protect a frail older adult just because they don't have the full power of the immune system to work with. And so they're not fully protected, but they're much better off would be the answer.
Andrew, I'm going to come back to you, but I'm going to keep on this line because there's some good questions coming in on this. Influenza, it pretty well disappeared this year. Is it going to be a threat? Is it going to kill thousands of older people again next year once the pandemic's over, or have we solved this problem too? That one I'm going to give you to Dawn too. Dawn, I'll get you to answer that.
Oh yeah, that was a Dawn question. Go ahead, Dawn.
Yeah.
Well, we will have influenza again. And will we have an influenza pandemic in our lifetime? Quite possibly, although I hope not. The thing that was just so exciting as an infectious disease researcher is just watching in real time what infections disappeared, and RSV, influenza are one of them. It's less transmissible than the coronavirus. And so all the masking and the distancing and things they really did work to stop those infections. And I hope that some of our lessons learned will keep those infection rates down. I hope that our long-term care facilities will be safer, but influenza will come back. It may be that we have another mild year in 2021, possibly even 2022, but it's not gone forever. There's just too many animal reservoirs that keep coming back to the human population. So you'll have to get a flu shot again, I'm afraid.
But have we learned anything from the pandemic? Will we do a better job of just letting people get sick in homes from the flu?
My sincere hope is that families, residents, staff, caregivers will now see that we can prevent infections. You know, I did feel in my pre-COVID life, I was sort of alone beating the drum that the influenza and to a certain degree pneumonia, we shouldn't have been accepting the high rates that we were in long-term care, but people just believed that was just, you know, an inevitable part, something that their loved one might die of. And I now hope that people have a better sense that with good personal protective equipment, infectious disease practices, great vaccination policies of both visitors, staff, and residents, that we can reduce that burden, and we shouldn't have the high rates of death that we've historically had in Canada.
And I'll just add one little thing. You used an acronym RSV, so I just want to let people know respiratory syncytial virus, a very common respiratory illness. Just not everyone knows the jargon, and so I just like to make that. Now, Andrew, your tough question is this one. People want to know more about models of care, you know, things like Butterfly, Eden, Dementia Village. Are these the solution? Should we be doing these more on a broader scale?
They are all the solution. You know, I think what they all emphasize is essentially person-centered care. They emphasize autonomy. They emphasize smaller. Smaller doesn't necessarily mean smaller buildings, but it means within buildings, places that feel smaller, feel more home-like. Places that are more separated. If you're respecting the autonomy and individuality of residents, you're giving them space. That's good for infection control. It's good for quality of life. If you're allowing them to congregate in smaller groups, they can develop strong bonds, good social relationships. That's good for infection control. If you have the kind of staffing model where the people that look after you every day, providing very personal care, like bathing you, et cetera, know you, they're consistently assigned to you. And so you know them, you develop relationships versus being mixed around every day. That's good for quality of care. It's good for infection control as well and isolation. So these things go hand in hand. All those models really emphasize that. You know, what we need right now, because we really need a revolution in long-term care, but also in options for aging. When we really need it now more than ever, as we have the baby boomer generation really reaching that retirement point. You know, all of those examples, all of those models, they're good. And so we shouldn't think about quabbling between them, maybe some small differences, which people might. They're all great. We should just really expand them. Now is the time. You know, people need to realize, and the conversations are being had now newly than they did before, about a third to half of individuals entering the retirement years will require congregate care living. And so they should think very seriously about what they want for themselves, what they want for their family members. Now is really the time to create it. And it means our changes in our healthcare system, but it means changes in zoning, retrofitting a lot of spaces, not just long-term care.
And you brought an important issue that I wanted to make sure I got to before we run out of time, is that we have to have these conversations, right? You don't want to have this conversation about where you're going to live when you're in crisis, and that's when it tends to happen. So tell us a bit about this, the importance of planning and how it makes a difference in your care ultimately.
If you don't discuss it, and if you don't mention it with family, if you're not a little bit prepared and a little bit knowledgeable, then you might not have the best experience. That's true for our entire society writ large, but it's also true of individuals. And so change starts with all of us individually. And so I think we can all be that change, speak to our family members, discuss options. You know, to your book, early in the book, the Wheeler family, who found themselves with parents in congregate care environments sooner than they thought they likely needed it. And after the fact, they realized that there was home care options that could have kept loved ones at home for a lot longer in a place where they would have wanted to be, rather than in congregate care environments that were a little bit stressful, maybe too expensive at that time, that maybe weren't quite required. And so we need more options. We need better home care. People need to think about their own homes, their own environments. Is this a place for me to live and age? If it isn't, they should think about moving. They should think about communities that matter to them, places they want to be, being around congregate care environments of their choice. And that doesn't necessarily need to be funded congregate care like long-term care retirement homes. It could be an apartment block where, there's a lot of good living, older adults, good access to services. It might not be in your retirement years when you have more funding, that farm property you thought you always wanted out in the middle of nowhere. You might not have good access to services. And so people need to make good choices.
So let's put you guys on the spot about good choices. You're both young, but how do you want to live out your final days? What discussions are you having now while you're still young and healthy? Dawn, how do you think this through after interacting with so many elders in care?
I think, one of the things that I think is so important is community at any stage in life. And, I really think about my grandparents, who I was very close with. And when they started losing their friends, that was a time for them to move into a congregate living because they were social people who had a lot to give. And so when I think about myself, I think, I would like to live somewhere with, I think, roommates. My 20s was awfully fun having, people around, like-minded people who like to do the same thing. So I definitely am not afraid of the idea of moving into sort of a community, but I'd also like it to be somewhere. The most peaceful sound in the world, I think, is children playing on a playground. So I would really like to imagine, our school grounds being near our communities for older adults. Because, the older I get, the more my own family, my own parents and children interact, and how disruptive this pandemic has been, I really do believe that strong communities are multi-generational, and that our older adults have so much to give to younger people, and younger people have so much to give to older adults. So for me, I like the idea of having integrated living in communities where young people and older people get to mix, and walking is, something that's really encouraged. So for me, that's sort of the idyllic vision of having some fun older roommates, as well as access to my grandchildren.
You're describing places that I visited in the Netherlands, in Denmark, where they take care homes and they're attached to daycare centers or schools so that there's that interaction. And it's really a philosophy that says, we care about older people. We want them to be part of the community. We want kids to see older people. We want people with dementia to be part of our world, not hidden away. So it really is about philosophy when you come down to it. So Andrew, I'm going to put you on the spot with the same question. You've talked to people about the importance of having the conversation. How do you want to live out your days?
Well, I like Dawn's option, so I'll be there probably. But
you've got a roommate, Dawn. Here you go.
Yeah, research to the very end, I suppose, or as long as we can do it. So I think for me, I kind of imagine that there might be cooperative arrangements between people where different groups of individuals in different places that value different things can kind of get together, live together, organize themselves in the way that people live normally, and have some planning around what that looks like. However, if at some point I need a more an environment like a publicly funded long-term care environment or privately funded, we don't know what the future holds. There might be some rationing around our public services going forward, but I don't live in fear of going into a long-term care home personally, because I know so many individuals that actually live very fulfilled lives, and there's a way to do it. And I think we're going to get there. I think we'll have options for everybody.
Okay. So one last question. I always like to end on a hopeful note, our panels. So I want to ask each of you, what gives you hope going forward that things are going to get better, as people who know the sector so well? Andrew, I'll stay with you. What's the hopeful thing you're going to send people home with?
I would say, for me, it's choice. And I think the conversations that were happening now, long overdue, I think we can catch up and make the smart choices as society, as individuals, that really suit the needs. And we'll have to do it. So I think that's how I know it'll get done as well. But I think the conversations that we're having like these are really important. That gives me hope.
And you've used the C word. We don't use that word a lot in Canada, healthcare system choice. That's sometimes a dirty word, but it's a good note to end on. Dawn, final word, what gives you hope going forward?
What gives me hope is it's not just Andrew and I fighting away quietly in our ivory tower now. I think, the horrible tragedy in long-term care has really mobilized all sorts of people. And I hope that everyone, all our listeners, when their politicians come to them and are lobbying for the next election, I hope the question they ask them is, what's your plan for long-term care? And let's all really use this momentum so that the burden of change does not rely on the caregivers who are already so overtaxed. And let's really push towards making this a real provincial, national, municipal concern. So thank you for making the time to do this, because I think it's so important that that message gets out. Now is the time for change, and I think we've got the right critical mass to do it.
Great. And like you, as researchers, as a journalist, I have the privilege of talking to lots of older people in their 80s, their 90s, the hundreds, and they're very thoughtful and they're outspoken at that age. And I hear the same thing over and over again. I hear people say they're not afraid of dying. They're afraid of being forgotten. They're afraid of, just being neglected. And the same three words come up all the time. People want to live with autonomy, with dignity, and being respected. So that's how I'm going to end with those three really important words. And I want to thank both of you for your really thoughtful comments, the audience for some really fabulous questions, and of course to McMaster for organizing tonight's discussion, which is very timely and I hope has given a lot of people a lot of food for thought, but also a lot of hope. So thank you all, and we'll see you at the next McMaster talk, hopefully.